But thank you to everybody and welcome to the session of the Genomics Lunch and Learn webinar series. I'm going to be talking on genomic testing, consent ethics, and research essentials. So my name is Philandra Costello. I am the lead nurse with the Central and South Genomic Medicine Service. Just a bit of housekeeping, so to make sure everyone does get the most out of the session, please keep your microphones muted to avoid background noise, because it does help everyone hear clearly. The session is being recorded. I know your cameras are turned off, but if you do have your camera on, if you don't want to be recorded, you can turn it off. And if you have any questions, please feel free to use the Q&A or to add your question into the chat. You'll also find some polls popping up at various points, and my colleague Vicky will be getting those up for you as I go along. So I think before I begin, what I want to make clear is that what I'm covering today is not an in-depth guide to genomic testing. Instead, it's an introduction to some of the core values like consent, ethics, research that come with genomic testing, that we should all be practicing and be aware of when we are supporting our patients through genomic testing. So even if you're not the one ordering the tests, many of you are the first point of contact for patients and their families. So your role in helping them understand what this means is absolutely vital. And if you've no prior genomics experience, that's not a problem. What you need is a desire to support your patients and your family safely and confidently. So I'm going to cover what genomic testing is, the National Genomic Test Directory, why informed consent matters, the ethical considerations, the National Genomic Research Library, and finally, how you fit into this picture and where you can go for further support and learning. Because as someone once said to me, why does this matter? Why do I need to know? I don't even order genomic tests. Well, actually, you're the ones that the patients trust when they're anxious or confused. So that is why it matters. But also, all of this supports the goal of delivering personalized care and precision medicine, and that is offering the right test at the right and the right treatment to the right person at the right time. So genomic testing doesn't just stop with one person. It can shape the health of entire families across generations. So when you think genomics, think family. A single test, like one detecting a BRCA gene variant, doesn't just affect the individual. It can also lead to life-saving care for siblings, children, and the wider family. And this is the power of one test, many lives, results that reach far beyond the patient in front of us. And because this information carries such weight, we must handle it with compassion and care. So I thought it'd be good to have a quick refresher from the last session. DNA is the body's instruction manual, which is found in all our cells. We get half from our mum and half from our father through chromosomes. DNA is organized into genes, which give the body instructions like how to make proteins. Genetics looks at individual genes. Genomics looks at all of our genes together, our genome, which gives us the full picture. Sometimes there are changes in our DNA code. These are called variants or alterations. Some variants are harmless. Others might increase the risk of illness or affect how we respond to medication. Traits like hair color or how we process drugs come from genes. Inheritance is how these traits or health conditions pass from parents to children. And remember, we're all 99% genetically the same. And it's that tiny difference that makes us unique. And that is basically my very quick refresher, but you can find more information on last month's recording. So what is genomic testing? Well, genomic testing looks at a person's DNA or genome to help understand, diagnose, or manage health conditions. It's a powerful tool that supports more personalized care, and it can be used at any stage of life, from before birth or even after death, to help explain sudden or unexplained illnesses. It can often uncover inherited conditions, and it can help guide care or testing for at-risk relatives. But there are three things that we need to consider. Is this the right test for the patient? Will it give us some useful, clear information? Will the results change how we manage them? Could it influence treatment, surveillance, or planning? What are the wider implications? How will the results affect the patient's family or future pregnancies? So what are the different types of testing? We have diagnostic testing for people with symptoms to find out if there's a genetic cause. And this uses gene panels, or if needed, whole genome or whole exome sequencing. For example, if we want to find out if we have a child with a developmental delay. We have predictive testing, and that's for people without symptoms but may be at risk due to their family history. And that uses single gene panels tests or panels. And that's, for example, if we're testing for Lynch syndrome. We have carrier testing, which checks if someone carries a gene that can be passed to children, and that can use targeted testing if the family variant is known, or screening panels. So think of cystic fibrosis or sickle cell disease. We also have prenatal and newborn testing, which looks at a baby's DNA before or just after birth, and that can include non-invasive prenatal tests or the newborn heel prick test. In sick newborns, we may use rapid whole genome or exome sequencing. We have pharmacogenomic testing, which looks at how genes affect response to medications, which uses targeted genotyping or drug response panels, and we have the DPYD test currently. We have tumor or somatic testing, which analyzes genes in a cancer tumor to guide treatments, and that can be used with, we use tissue or blood, and we do liquid biopsy or ctDNA testing. Whole genome sequencing and whole exome sequencing is when we are doing broad testing, or we're looking at all or most of the genes to find answers in some of those complex or rare conditions. And cascade testing, which isn't a test itself, but a process, and that's where we test close relatives after a genetic diagnosis in the family, and we use targeted testing for that known variant. So in summary, some tests to help us diagnose, some tests predict future risk, some tests guide treatment, and some help protect families. And as genomics becomes part of everyday care, it is important that we recognize when it may be useful, ask the right questions, and know when to refer patients and to do the process confidently. So you might have heard of the National Genomic Test Directory. Well, what is it? It is the official list of genetic tests, genomic tests that are available in England, the types of test methods, patient eligibility, and who can request the test. The test directory is a practical tool developed to help standardize care and avoid unnecessary testing and support accurate and timely diagnosis. By recognizing when to refer and using this resource effectively, we can help patients access the right genomic insights at the right time, which can improve outcomes and in some cases even save lives. And it's designed to ensure that everyone, no matter where they live, has access to the same tests. And just for information, in the past year, over 850 genomic tests and counting have been carried out in England. So the tests are grouped into two main categories. We've got rare and inherited disorders for conditions like developmental disorders or inherited heart problems, and we have the National Cancer Test Directory as well. The Rare Disease Test Directory does look like this, and you will find the test ID for rare disease and the clinical indication, and it's prefixed by the letter R. The genes to be tested, the test method. So is it a panel test, or is it a whole genome sequencing or whole exome sequencing? Which specialty the test is used, and where you'll find more information in the eligibility criteria document. The eligibility criteria document goes alongside the Rare Disease Test Directory and gives detailed information on patient eligibility, when to do the test, at what point in the diagnostic pathway, which clinical specialties can request the test, which is nationally agreed but is flexible, the type of the test, the method, For example, is it a whole genome sequencing test or is it a panel test? And who to test in the family if needed. So are we only testing the patient or do we need to test the trio, so the parents and the child? The cancer test directory is split into solid tumors, neurological tumors, sarcoma, hematological, and pediatric cancers. And the structure is similar, but it's tailored to tumor types. The clinical indication or the test ID is prefixed by the letter M, and the eligibility criteria can be found here. And for both directories, there are explanatory notes. So remember, R for disease, for rare diseases, and M for cancer. Both directories support clinicians in picking the right test with the right criteria. So that is your test directory that is found on the NHS Resources website. So what is informed consent and what does it mean when it comes to genomic testing? So informed consent is not just about getting a signature. It's a meaningful conversation where patients and families generally understand what they are agreeing to. And genomic testing can reveal complex and sometimes unexpected information. For example, a patient referred for testing due to unexplained arrhythmias might discover a genetic variant linked to an inherited heart condition, and one that could also affect their children or siblings. And that's why this isn't just a quick yes or no decision. It's a process, and our role is to support understanding, answer questions, and respect the patient's right to choose, including the right to say no or take more time to decide. And what does good consent look like in practice? Well, it starts with preparation, so thinking carefully about the individual patient or the family in front of us. So communication barriers, are there any language literacy issues, or is it just the complex ideas that we need to adapt to? We need to think about using translators, easy read materials, visual aids, or simply just take more time. Clear explanations. We need to use plain, accessible language to explain why genomic testing is being offered and what we might learn, including both the potential benefits and the limitations. Honesty about uncertainty. Some results may be uncertain or unexpected. So we should be preparing patients for this possibility from the outset, especially when we're using whole genome sequencing or whole exome testing. It's part of setting those realistic expectations. And think about family impacts. Genetic results often have wider implications, and a finding may be relevant to parents, siblings, or future children. And those connections must be part of that conversation. Data reassurance, we need to explain clearly how genomic data will be stored securely and used appropriately and where relevant. So where might it be shared for research? And we need to ensure that we have the patient's permission for that. An ongoing choice. Consent isn't a one-off box ticking exercise. Patients can change their mind at any point before testing is carried out. It's a process that may need revisiting, and especially in certain situations. With children, their ability to understand grows over time. So we need to think about revisiting and adapting consent conversations as they mature. And if someone lacks capacity, we need to follow the Mental Capacity Act and involve families or advocates, always working in the patient's best interests. The NHS Genomics Education Programme Consent Competency Framework underpins this approach. It sets out clear expectations that we support patient understanding, discuss uncertainties and potential implications, and promotes shared decision making. And it reminds us that consent isn't just about process, it's about people. And our role is to ensure that patients and families feel heard, informed, and empowered at every step. And how we handle consent matters just as much as the science behind it. So for whole genome sequencing, there are two main documents that are required. First is the test order form, or the TOF. This is where we request the test, and it's normally completed by the referring clinician. There are separate test order forms for cancer and rare disease. And what is extremely important is that all the required fields are completed in as much detail as possible. And really, this is to ensure that there are no delays in the test being carried out, and that the right test will be carried out. It also helps to ensure that the analysis comes back in as much detail as possible. And secondly, the consent form, which is known as the record of discussion. So the record of discussion is more than just paperwork, and it provides, it proves that we've taken the time to talk through the test with the patient or the family. For whole genome sequencing, it's mandatory to have a record of discussion, or a ROD, accompany the test order form. And this document guides us through what we need to cover. So, and what the test might find, how the results could affect the family, and what will happen with their data. There's also the choice to be part of the National Genomic Research Library. And then finally, the third page is whether they agree to go ahead. So it helps patients feel confident and informed, but it also helps protect staff too. And it's important to know that whole genome sequencing isn't the only testing that requires meaningful consent, but it is the one with the most structured documentation. And you can find all the forms and the resources, including the versions for people without capacity, on the NHS Genomics website. They also have patient-friendly leaflets to support those conversations. For all non-whole genome sequencing tests, there are different requests or referral forms, and that depends on your region, and that can be found on your Genomics service website. With regards to the test, the record of discussion, there is consultation going on at the moment looking at that form, so there potentially could be changes in the future. So genomics consent isn't always simple, and it shouldn't be rushed. There are several challenges that we need to consider. We need to think about the complexity of genomic data. The science of behind genomic testing can be difficult to explain, so just making sure we're using clear, plain language and use relatable examples, and it's really essential. We need to think about the emotional impact. Results can be unexpected or upsetting, and especially if they're uncertain or reveal a serious condition. We need to think about those family implications. Some results may indicate that relatives are also at risk, which can lead to some challenging conversations and decisions. So that big question overall, who needs to know about these genomic results? And our role is to guide patients and families through this process honestly, and ensure understanding of the risks, the benefits, and those limitations. Imagine if you had a patient saying, I wasn't prepared for this after receiving that difficult news. Or consider a scenario where whole genome sequencing in a child reveals that the presumed father is not biologically related, and something that the wider family was completely unaware of. So whilst rare, these situations are deeply sensitive. And that's why it's crucial to explain upfront that genomic testing can occasionally reveal unexpected information, including non-paternity or other unexpected familial relationships. Being transparent about that possibility before testing can help reduce distress later, and it helps protect that trust in the clinical relationship. So informed consent is about ensuring patients and families truly understand what testing can reveal, and it's about giving them time and space to consider whether they're ready for that information. Rushed or superficial consent undermines autonomy, and it can actually damage trust. And by supporting thoughtful, informed decision-making, we help patients engage with genomic testing in ways that's respectful, empowering, and grounded in care. I think it's also important just to be aware that people can buy genetic tests over the counter or online, but there are worries about those DIY DNA tests like 23andMe, because people might not fully understand what they're signing up for, like their data being sold or shared. The results can also be misleading, that can cause false reassurance or unnecessary stress. There's lack of counseling. Most companies don't provide support, and there's a risk of hackers. So current rules do stop insurers from using most of this data, but there are gaps. So my advice is just proceed with caution and seek advice. So just to address that other common concern is, will this genetic test affect my insurance? With insurance, dependent on the policy, you may have to disclose all relevant medical history, which you should. But thanks to the moratorium agreement, which is a voluntary government code agreed with the Association of British Insurers, or the ABI, most predictive genetic test results can't be used by insurers, at least until 2027. So insurers can't ask for or pressure anyone to take a test. However, if someone has had a predictive test for Huntington's disease and is applying for life cover over £500,000, that can be asked for. For diagnostic tests, so those done to explain symptoms, those are treated like any other medical diagnostic test. And if you're a carrier but show no symptoms, you don't have to disclose that status either. But it's worth reminding patients that insurers can still ask about family history, because the moratorium only covers those actual genetic test results. So you can find more information from the ABI or the Genetic Alliance UK, or otherwise there is your local genetic service that you can also refer to. So genomic testing ethics really comes down to respecting people's rights while recognizing our broader responsibilities. Genomic information is unique because it is shared amongst family members, and this shared nature can lead to complex ethical questions regarding confidentiality and consent, and how you balance the rights of the individual with familial responsibilities whilst thinking of those family dynamics and communication concerns. So we need to think about how we're protecting patient autonomy and confidentiality. So think of the psychosocial aspects, which can be significant and can lead to feelings of anxiety, guilt, and stress for patients and their families. Informing relatives of genetic risks can be a heavy emotional load. Communicating genomic risk information to children, is it age appropriate? We also have to be mindful that genetic information can impact identity in sometimes in profound ways, and it might challenge someone's sense of self or cultural belonging. There's also a real risk of discrimination, whether in healthcare, employment, or insurance. And we know that some groups face greater risks here. So we need to be especially careful with some of our vulnerable populations. Cultural sensitivity is crucial too. Many communities have valid concerns that are based on historical experiences or spiritual beliefs, and we have to acknowledge the diversity gap. Most genomic data comes from European populations, which can affect accuracy for others. So, for example, a patient from a South Asian background may have a genetic variant that's classified as uncertain because of underrepresentation in the data. So that makes that result less useful, but potentially confusing. Supporting diverse patients means building trust, offering language support, and including underrepresented groups in research. And when patients hesitate, like saying these tests aren't for people like me, we should acknowledge their concerns while explaining how participation helps make medicine more inclusive. So our role is to guide patients through these complex decisions with compassion and clarity. And when those challenges arise, then this is where we need to think about consulting and working with genetic services. Genetic counselors play a vital role in helping individuals and families. We need to utilize interpreting services for patients with language barriers to make sure that the information is being given clearly. We need to think about signposting to organizations like Genetic Alliance UK for additional patient support. Ethical genomic practice isn't about having all the answers. It's about asking the right questions. Is this test in the patient's best interest? Have we explained it properly? Could anyone be harmed by the results? And by keeping these principles at the heart of our work, we ensure that genomics serves all patients fairly and compassionately. If you're ever unsure about what to say to a patient or how to handle the results, that's when your local clinical genetics team or the genomics medicine service can support. So don't carry it alone. If you're interested in learning and understanding more, the 2019 British Society for Genomic Medicine report provides guidance on ethical issues and misconceptions in genomics consent and confidentiality. Genomic research is vital in helping us to understand and treat inherited conditions and other genetic diseases. And it matters because research lets scientists study our DNA to spot genetic changes that cause disease. That knowledge can lead to better diagnosis and more targeted treatments for patients. And what does that mean for patients in practice? Well, earlier detection. If we can identify genetic risks sooner, we can step in earlier to prevent or manage conditions before they become serious. And also personalized treatments. Because we're learning how to match treatments to a person's unique genetic makeup, we're not taking a one-size-fits-all approach. And finally, better care overall. As research progresses, we're developing more effective therapies and clearer guidelines to make sure that every patient gets exactly the right support for their situation. But as I said, there is that catch, as most genomic data comes from people of European ancestry. And that is a problem because genetic variants can differ across populations. Without diverse data, tests might miss risks for certain ethnic groups, or treatments might not work as well. So that's why including everyone in research isn't just fair, it is essential. So the National Genomic Research Library, or the NGRL, is like a treasure chest for medical breakthroughs. When patients have genomic testing, we ask if they'd like to contribute their anonymized data to the secure database. It's always completely optional. It holds over 200,000 whole genomes, which are cancer cases, rare diseases, and linked healthcare records to track how conditions progress. But here's the crucial bit. Every piece of data is anonymized and locked down tight under strict GDPR compliance and ethical oversight. And researchers only get access after rigorous approval. So it isn't just about storing data, because it's already making a difference. We're talking about new cancer drugs and better rare disease tests that have been developed. So these are real breakthroughs. And remember, the NGRL is totally optional and patients can withdraw at any time. Patients often ask two big questions. Will my data actually help? And the answer is absolutely. Every contribution gives researchers clues to develop better treatments. And secondly, is my information safe? Yes, it's anonymized and protected by UK GDPR, and it's stored in these fortress-like systems. So it is quite secure. Pharmaceutical companies never get raw data. Any discoveries must benefit patients first. And for example, if a patient asks or is worried that drug companies might profit from their DNA, we need to explain that researchers may work with companies to develop these treatments, but actual data stays protected in the NHS, and the patient is always in control and can withdraw at any time. So the bottom line is that the library is transforming healthcare while putting patient choice first. And every participant is helping to build better medicine for future generations, but only if they choose to do so. So to summarize, the test directory is there to guide appropriate test choices. Informed consent is essential. It needs to be tailored, it needs to be clear, and it needs to be ongoing. Ethical and cultural issues are complex. Support and sensitivity are key. And if in doubt, seek support early. Research drives discovery, but must be equitable. And all of this supports our goal of personalized care. Remember, it isn't done in isolation. A multidisciplinary team, including clinical genetics, genetic counselors, nurses, specialists, should be supporting patients every step of the way. You might not be the one that is ordering the test, but you can be the one who makes it safe, ethical, and understandable. And you do support your patients before, during, and after genomic testing. And your role can include spotting those red flags in family histories or clinical presentations, explaining what to expect, supporting that decision making, advocating for equity and ethical care, and referring to specialist teams as needed. And just so you know, on GE Notes, you can also find the clinical genetic services map if you're looking for where they are based within your area or your region. If you're interested, you can hear some powerful first-hand experiences on genomic testing from those who have been through it in our upcoming Central and South Genomics webinar, which will be on the 15th of August between 12 and 2 p.m. To help you feel more confident discussing genomics with patients and families, there are several educational resources available. We've got the Genomics Education Program with free CPD accredited modules, bite-sized courses. E-Learning for Health has genomics programs, including consent and how to thinking about that consent conversation. They are also in the process of moving some of this over to the NHS Learning Hub. But you can also find the fantastic genomics learning passports for midwives and the genomics learning passports for nurses, which help you, which provide you with a structured way to track your genomics learning. And they have been designed with you in mind. So whatever your role or level of experience, they can also be used to add to your revalidation. GE Notes is also available and free to access, and there you can find easy to use guides that can be used in the clinic. And also, if you want to find out more, there is also the Knowledge Hub that is available. Your local genomics medicine websites and region where you can find regional updates and educational information as well. If they provide training, local training, and they also provide support networks. So on the map there, you've got the different colors for the different regions with the QR codes for the different areas as well. And don't worry, all of this is going to be shared with you and this has been recorded, so you can find that information. Finally, our next webinar is coming up and it is Genomics for All, Practical Family History Skills for Holistic Care, which is going to cover the importance of family history in genomics and some practical skills on Wednesday, the 23rd of July, between 1 and 1:45 p.m. So thank you all for listening. We do have a post-session feedback survey, and it is really important to get your feedback because it just helps us going forward. So I would really urge you all to complete that. And we will send you the links of where to find the recordings and download you can also download your certificate of attendance. So thank you very much. And I'm going to stop sharing so that I can see my screen. But does anybody have any questions? Just going through the chat because I can see. Sorry. Okay, I'm looking at some of the poll responses, though they're quite interesting. And for those that are not feeling confident, you can be reaching out to your local genomics medicine service, where you will be able to get support either from clinicians or your lead nurses. Sorry, I'm just going through this quickly. I've just got the first question is what's a panel test? So when we're talking about panel tests, normally we have genes that are known to be linked or associated to certain conditions. And so there will be a number of genes on a panel that are known to be linked or associated with the test or with the condition that we're trying to look into further. So that is a panel test where it includes a number of genes. There's the next question is when discussing genetic testing, some participants mention that their religion does not permit it. And how do you usually respond in such situations? I think that is an interesting and situation to be in. Really, I think for me, the best advice that I can give is that as long as you've given all that information to that patient, they can also take that back to their religious faith leaders and also find out more from their faith leaders what they feel. But I think we have to respect everybody's decision, and there are some dependent on what religion. There are some religions where certain treatments, for instance, with the Jehovah's Witnesses, where they do not accept blood transfusion. So we must respect people's choices and decisions on whether that they wish to go ahead with genomic testing, taking into consideration that why we're doing the genetic test. Is it to get an answer? Is it for treatment? And as long as that patient is fully informed of that information, I think we have to respect their decision. The recordings of the May webinar, I will get that information out to you. I think we are going to be saving them centrally, and I don't know if anybody's on the call that is able to give some clearer information there, but we will be sending the links out to everybody on where to access the information. I'm just going through. Are there any new drugs added or will be added to pharmacogenomics? So there's lots of work going on with the different genomics medicine services, looking at how they are going to be extending the pharmacogenomics panel. So we just have to keep an eye out from that, but lots of work and research going on into what drugs will be added or for pharmacogenomics.